Assalamu alaikum, everyone. My name is Atufa Najm, and with me here is Dr. Nusrat Irfan Malik. I'm part of the Pediatric Psychosocial Department, whereas Dr. Nusrat is a consultant radiologist. Together, we are part of the Clinical Ethics Committee at the Indus Hospital. Initially, first, we welcome you all to our session that has been organized by the Clinical Ethics Committee on the theme of prolonging life or prolonging death. As healthcare teams, we are constantly involved in so many decisions. So many complex decision making situations come across us every single day. The dilemma of whether to continue life sustaining support or should we withdraw it. These are the questions that always come across to us. This dilemma and these decisions involve multiple stakeholders and multiple perspectives. Knowing how or when to make this determination is quite tricky. In this session, we plan to address the concern and assist the healthcare providers in determining the best course of action for adult and pediatric patients. We will discuss about the aspects of communication, policies, and religio-cultural factors that are associated with these decisions. We will first begin our session with a talk, and then this will be followed by a panel discussion. For our talk, the first conversation that we will be having is about the aspects of communication, which will be presented to us by Dr. John Lantos. Dr. John Lantos is the professor of pediatrics at the University of Missouri, Kansas City, and director of the Children's Mercy Hospital Pediatric Bioethics Center. He has published over 400 peer reviewed papers and book chapters and 10 books. He is the former president of the American Society of Bioethics and Humanities and currently serves as on the American Academy of Pediatrics on Bioethics. Thank you so much. We will move on towards the presentation now.
John Lantos, it's great to be here with you, even virtually. I wish I could be there in person, but maybe next year we'll be looking back at COVID. Let's hope. I'm going to talk today about some of the issues that come up in bioethics at our Children's Hospital-based Bioethics Center, particularly about communication both among professionals and between professionals and parents when there are controversial cases, especially cases that involve differences in fundamental belief systems like religion or cultural factors. I have no conflicts of interest to disclose for this talk. Let me start by telling you just a little bit about me. I'm a general pediatrician. I have a long-standing interest in taking care of children who have complex chronic disease. These are children who some are ex-preemies, some have genetic diseases, but they're often sort of on the edge of what's known scientifically or for which there are treatments with good evidence base. I also work as a bioethicist. I spent 20 years at a specialty hospital for kids with chronic disease in Chicago. You can see the little guy there on the right of the screen, happy. A little toddler with a tracheostomy, probably from bronchopulmonary dysplasia. About 15 years ago, I moved from Chicago to Kansas City and now run a children's hospital-based bioethics center that also runs a teaching program, a certificate training program that many people from Pakistan have participated in. We have people from all over the world, and so get to hear about a lot of different cultural practices, different practices in different countries, and to think about the implications of religion and culture, and particularly where we come from. One of the articles that I think best addresses this comes from a physician philosopher, Carl Elliott, who's at the University of Minnesota. This was published about 30 years ago, and he says in this paper, I myself refer to no systematic moral theories or doctrines in making moral judgments, but I have no illusions that these judgments are independent of the fact that I grew up as a Presbyterian in South Carolina, that is both religious roots, but also cultural roots. A particular part of the country, a particular culture shaped his worldview, as it does, I think, for all of us. And so some of the questions that I hope you'll think about today have to do with where our ethical values come from and what is the role of religion or culture or personal philosophies in our own values and the values of the patients and families for whom we provide care, and to question whether these fundamental values, the ones we grew up with, are values that can change or ought to change. And if so, should they change because we've reasoned our way to a different conclusion? Or do they change because circumstances, stories, cases, real life events lead us to feel things that create conflict between what we think of as the right thing to do and what feels like the right thing to do? Really, the question behind all of this is, when should we live out our uh, um, values we've grown up with? When do we stand firm? And when is it better to bend or compromise, to perhaps change what we think of as the right thing to do in a particularly challenging circumstance? It's interesting that over the years we've seen some changes in some places for many different reasons on a lot of fundamental moral issues. Slavery used to be legal in the United States. Now it's prohibited. Ideas about gender relationships and sexism have changed. We've come up with new definitions for what it means to be dead, the idea of brain death. Withdrawal of life support used to be considered homicide or manslaughter or euthanasia. There are big debates about abortion and disability rights and the meaning of life with disabilities. And of course, informed consent is a relatively new concept that is not part of most ancient medical ethics systems, but has come to take a central place in most modern ethics systems. Again, these are ideas that forced people to change their fundamental views about what the right thing was to do in circumstances. So, change is always hard. It raises questions about the nature of our deepest moral convictions. And it leaves people open to the charge of being moral relativists, of not holding firm to important and fundamental values. Flexibility can be seen as spinelessness or wishy washy approaches to moral dilemmas. And so moral change induces deep and inchoate, that is hard to understand, anxieties, but is sometimes necessary. So, with that as background, what I want to do today is present a couple of cases that have come to our ethics consultation service and that forced people to think about uh, their own fundamental moral values, and then talk about how we as communities of health professionals, as I would say moral communities, come to understand what's at stake in these cases. So these are cases from pediatrics. So for those of you who are not pediatricians, I'll try to make some of the clinical facts clear. This was a case of hypoxic encephalopathy. A baby was born at full term. There was a cord prolapse that led to prolonged anoxia, and the baby's initial blood pH was 6.7. Apgar scores were 1, 1, and 1, indicating profound depression, uh, physiologic depression, unresponsive to resuscitative efforts. But the baby was successfully resuscitated, was treated with hypothermia, as is the standard of care now for cerebral anoxia, and survived with a gag reflex, but no suck or swallow. In fact, the baby's only neurologic response was to withdraw from painful stimuli, although she was breathing on her own, so clearly not brain dead. The doctors sat down with the parents and recommended a do not resuscitate order. The parents agreed to that. The doctors then recommended a gastrostomy tube so that this baby who could not suck or swallow would be able to get adequate nutrition, and the parents disagreed and instead requested the discontinuation of any artificial fluid and nutrition. This was the first time in this hospital's experience, this group of practitioners' experience, that parents had requested stopping feeding. So they turned to sources of moral wisdom or professional standards. The American Academy of Pediatrics has a guidance about foregoing medically provided nutrition and hydration in children, and they describe cases similar to this one in which they say it's permissible if the burdens of treatment outweigh the benefits, and for a child who's thought to have uh, 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 no hope of recovering consciousness or making any neurologic progress, the benefits of treatment, according to the Academy, are minimal. The burdens on the family are enormous, and so it's permissible to stop artificial fluid and nutrition. Other sources of moral wisdom, like the Catholic Church, say it is never permissible, that we can only withdraw extraordinary treatments, and fluid and nutrition should always be considered a basic necessity of life and ordinary treatment, and it is always morally impermissible to withdraw those treatments. Those were the experts, but they mirrored the sentiments of the people working on this case, and there was intraprofessional moral disquiet or moral unease. In this case, doctors and nurses disagreed about what the appropriate response was to the parents' request. The staff was aware of the AAP's policy. Some quoted Catholic or other religious doctrines, but everybody seemed to have a strongly held opinion about what the right thing to do was in these circumstances. They just disagreed with each other. And in a sense, this case illustrates what it is that we talk about when we talk about ethics or clinical ethics or tough cases that raise ethical dilemmas. Is a description of the key criteria for an ethics dilemma in clinical medicine today. All the choices are bad, all the options are legal, fundamental principles conflict, reasonable people disagree, and a decision must be made. There's no non-decision option. Either this child will be fed or won't be fed. In theory, you wouldn't have to put in a G tube. You could continue NG feeds, but the parents didn't want that either. So in this case, everybody agreed that all the choices were bad. The baby would either die of starvation or live with no cognitive awareness. Everybody agreed that a choice must be made. The options were legal and reasonable. People disagreed. People made many defensible moral claims. Some people said parents have the right to make this decision. It's their baby, it's their life. They're the ones who have to live with the consequences. This decision properly belongs to them, and our job as professionals is to counsel them, guide them, offer recommendations, but ultimately go along with them. Other people said babies have a basic right to fluid and nutrition, essentially the view of the Catholic Church, that this is not a medical treatment, this is a fundamental necessity of life, and this should not be within the zone of parental discretion. It should not be something parents are allowed to make a decision about. It's simply not an option. And in response to that, people said that artificial fluid and nutrition is or is not different from other medical treatments. In other words, is a G tube and a formula given through a G tube more like giving a baby a bottle or the breast, or is it more like giving a baby antibiotics or dialysis? There were many powerful emotions. Somebody said it's like taking away a blanket. We would leave a baby naked on the front steps. Somebody said what made it so hard was that it took so long. When we stop a ventilator, babies die quickly. Other people thought that involving the health professionals at all was inappropriate. This was what the parents wanted. They should take the baby home and provide care themselves. That involving people who objected to this was itself morally problematic. Interestingly, studies show that health professionals have different attitudes about withdrawing mechanical ventilation than about withdrawing either TPN or enteral tube feedings. This is a complicated graph, but basically the darker the line, the more comfortable or in agreement people are. So at the top there with withdrawing mechanical ventilation, almost everybody surveyed here, and these were doctors and nurses working in NICUs, said it's permissible. They agree that it's sometimes acceptable to withdraw mechanical ventilation. But if you go down to tube feeding, you see there's much more disagreement. Many more people are very uncomfortable or strongly disagree that it's appropriate to withdraw either enteral feeding or parenteral feeding. So the attitudes in this particular group mirrored findings in a broader survey of professionals. And this is a feature of many moral dilemmas. Alistair McIntyre is a theologian who taught for many years at Notre Dame University. And in his book, After Virtue, he says the most striking feature of contemporary moral debates is their interminable character. They just go on and on. There seems to be no rational way of securing moral agreement when people have these fundamental disagreements. Or Stuart Hampshire, another philosopher, who wrote a book about conflict and justice, says there's normally in modern society a chaos of opinions and moral attitudes. And a reasonable person hopes for a consensus, usually one in which their own attitudes and opinions are dominant. That can't always be the case. Somebody will have to compromise. Somebody will have to uh, give up their strongly held moral opinions if we are to continue to work together as professionals in a moral community or as citizens in a pluralist society. So, what should give, and how should the process of getting to agreement take place? Let me leave that case for now, uh, present another case that illustrates similar issues. Another baby, in this case with bad bronchopulmonary dysplasia, the chronic lung disease that premature babies get. We'll call her Jasmine, who was born very prematurely at 24 weeks, 550 grams, at a prolonged course in the neonatal intensive care unit, and ended up with bad bronchopulmonary dysplasia. She was dependent on a ventilator, had high mean airway pressures, a sign of the severity of her disease. She required a tracheostomy to continue her mechanical ventilation, a G tube for feeding. She was in constant pain and got continuous narcotics and was thought to have cognitive impairment, although was so heavily sedated much of the time that it was difficult uh, to determine her cognitive status. The doctors sat down with the family, recommended withdrawal of life support. The mother agreed, but the dad did not, and so life support was continued. After 6 months, Jasmine gradually improved. She was still in high vent settings, but she'd made some developmental progress. She smiled, she reached for toys, and interactive. She was interactive and seemed to be intermittently happy. The doctors still thought her lung disease was so bad that it was hard to know if she would ever go home, but everybody was pleased with the progress that she was making. She had weaned off her narcotics, and there was some hope at this point, particularly among the nurses, that the expert care that we were providing may lead to Jasmine's survival and maybe even a good quality of life. At that point, Dad requested withdrawal of life support. As background, the parents had had infertility problems. This pregnancy had followed years of fertility treatments and multiple rounds of IVF. The parents had been trying and continued to try to adopt another baby. And as we later found out, just before the request for withdrawal of life support, their long sought adoption was approved. And they now have a new baby, a healthy baby at home. So, how should the health professionals respond to the parents' request at this point to stop Jasmine's ventilator and let her die? The doctor's views, and it was pretty much unanimous in this case, Jasmine's terminally ill. She has severe lung disease. The treatment is very burdensome. The prognosis is bad. And the dad's request, actually the parents' request, since mom continued to agree, was quite reasonable, and the doctors were prepared to stop Jasmine's ventilators. The nurses in this case had a very different opinion. They cared for Jasmine, that's a typo, instead of years, it should be months. And now she was getting better. To stop now would make all her pain and suffering and all the work that the nurses did to take care of her meaningless. Furthermore, the nurses suspected the parents' motives and thought they weren't doing what was necessarily in Jasmine's best interest. But now that they had a new baby at home, they no longer wanted to put in the work necessary to take care of this damaged baby. We had some multidisciplinary conferences in the NICU, and as you might imagine, emotions ran high. There was anger, frustration, love, grief, suspicion, some disdain for the parents, some disdain for colleagues. These were not pleasant meetings. There was a lot of screaming, there was a lot of crying. And one of the things that surprised me was talking seemed to make things worse instead of better. The more we talked, the angrier people got. Nobody could convince anybody that their view ought to prevail. Instead, as we talked, everybody dug in to defend their own beliefs about what was right or what was wrong in this case. The anger, the sadness, the tears raised this fundamental question about moral philosophy and moral convictions. What is the relationship between these powerful emotions that we feel in some ethically controversial or morally stressful, morally distressing situations? What is the relationship between those strong feelings and our philosophical ideas or theological ideas, our spiritual convictions about what is the right thing to do? Should reason shape our emotions, or is it the other way around? Should our strong feelings tell us what philosophies we need to adopt? And can we learn to respond differently to a particular action or situation by paying attention to the emotions that set of circumstances generates? Uh, Philosophers have looked at this, and there are two models of moral philosophy that take very different views on how reason and emotion relate to one another. Margaret Little, is a philosopher at Georgetown University in Washington, D.C., and she describes what she calls the traditional or bureaucratic model of morality, where moral agency involves a clear division of labor by which reason is responsible for coming to moral verdicts about what is right or wrong. It then passes its report on to the will, motivation, and emotions, which take their orders from reason. This is the traditional view of many moral philosophers, by which logic prevails, by which we should try to eliminate mere emotional responses to situations, to try to cancel them out so that we can reason more clearly and in that way do the right thing. Professor Little contrasts this with an alternative model. She calls it a feminist model, where the possession of certain desires and emotions is crucial for seeing what morality requires. That is, moral judgments begin with a gut feeling, they begin with an emotion that is then passed on to reason to evaluate. Not all gut feelings are correct, but everything starts with those primal feelings. Martha Nussbaum's another philosopher who has looked carefully at this and agrees with Little. She says human emotions are not simply blind surges of affect derived from our animal nature, they have a cognitive content. And the correct perception of a practical situation requires emotional as well as intellectual activity. Emotions have a valuable informational role to play within the ethical life. And she talks about how people learn morality. A child does not learn its society's conception of love or anger by sitting in an ethics class. Emotions are taught to us by our culture by our religion, by the stories, by patterns of interaction between the child and others, and by recreations of those patterns. Children are taught culture and values through stories. We learn how to respond by hearing the stories of our people. And the great moral teachers have always used stories to convey moral lessons. But stories are complicated. They don't converge on a point often in quite the way that logical arguments do. So, figuring out how to evaluate stories, how to take moral lessons from stories is the work of the most subtle and sophisticated moral teachers. This process of learning from stories continues through adulthood, and in a sense, complex cases like the ones I presented today are the key stories for clinical ethics. The stories that I presented came from tertiary care children's hospitals in the United States, so they may not be the same stories that would arise in other situations. Stories in hospitals that care for adults are certainly different, and stories from hospitals in different parts of the world would certainly be different. But in my view, every place has stories that raise these complicated ethical conflicts that create moral disquiet among professionals. And we have to figure out what lessons to take from those particular stories. We develop an ethos, a collective view of what morality requires through these shared collective experiences. The doctors and nurses go through a case like this together and then start to tell stories about those experiences. And through those stories, we work out answers to tough questions like, what does it mean to care for a child with severe brain damage? When does caring mean continued life supporting treatment? And when does it mean allowing death to take place, letting go? What do we owe one another as colleagues as we go through the process of caring for such children? What do we owe to families? How do we work together when we disagree? And are some beliefs, some disagreements so intolerable that people cannot continue to work together? And the moral community will end up selecting people who share a set of values to be part of the community. And it will lead to a sort of moral pluralism within a culture where one hospital may take one approach and another hospital take a different approach. Philosophers have started to talk about this phenomenon as the development of what they call communities of practice. And this was a great article in the Journal of Medical Ethics just last year about how people are developing communities of practice around the COVID pandemic, but they arise and develop in response to every sort of controversial case. There are four characteristics of a community of practice. It's a joint enterprise. People are working together with mutual engagement, a shared repertoire of both practices and beliefs, and eventually a sort of collective practical wisdom about how to respond to these difficult cases. Richard Kearney is a philosopher who's looked carefully at the role of stories in conveying moral wisdom and creating a community of practice. And he writes in his book called Stories, a community comes to know itself in the stories it tells about itself. It is the capacity of narrative imagination to constantly transcend the status quo of any given society toward possible alternatives. In other words, this process of moral change that I talked about in dealing, this process of dealing with new situations that challenge us to at least reevaluate, if not overturn our fundamental beliefs, is a process that requires the telling of stories and the understanding of each character's motivation, each character's goals. Stuart Hampshire, who I quoted before, wrote that people who work together share fragments of a common ethic in their working life and a kind of moral complicity in the choices that they make. The role for ethics, and I say ethicist in this slide, but I think everybody is an ethicist in this sense. The role for thinking about ethics is to facilitate an inherently social process of moral inquiry. To have a community of practice, values need to be explicitly stated and ultimately shared. That is, we have to work together. We have to identify norms and actions that evoke these shared and stable social commitments. So we move ethics from the realm of an individual or private judgment to the arena of discourse and communal review. These quotes come from a wonderful article published about 30 years ago in a journal called the Hastings Center Report by a philosopher named Margaret Urban Waqar, who went on to say that the ethicist's special responsibility is to keep open, accessible, and active those moral reflective spaces in institutional life where a sound and shared process of deliberation and negotiation can go on. That is, to have the sort of meetings where people can express their anger, where people can cry and be heard, listened to, treated with respect, and hope. By facilitating this conversation, we can get beyond the anger, beyond the shouting, and come to some shared understanding, some moral reflective space where people can continue to work together. Stuart Hampshire again talks about this kind of moral complicity. Perhaps that's the best that we can hope for, is this understanding that we are, for better or worse, in this together. We are dealing with situations that are very morally stressful, and we need to help each other as we go through this and find ways to work together. People might want to know the outcome of the cases, but in this particular talk, the outcomes don't matter so much. The point is that different institutions might have resolved these cases differently. Some places might develop a community of practice in which withdrawal of artificial nutrition and hydration is acceptable. Other places might develop a shared understanding that no, it's not acceptable. We never withdraw fluid and nutrition. That's an ordinary rather than extraordinary treatment. Similarly, with the long-term ventilation for Jasmine, different institutions might respond in different ways, but the point is to develop a process within each institution whereby a community of practice can develop. So I look forward to discussion. Once again, thank you so much for inviting me. Thanks for your attention. And again, I wish I could be there to enjoy the discussion in person.
So, for our panel discussion, we are joined by Professor Jamshed Akhtar. He is the visiting professor at NICH and JSMU. He is the Dean, Faculty of Pediatric Surgery, CPSP. He is also the member of National Bioethics Committee. He has served as a member of ethical review committees at Ziauddin University and JSMU. He is the chair of ERC at the Kidney Center, Karachi, and NICH. He's also teaching diploma on the healthcare ethics and professionalism at the Shalimar Medical College, Lahore. Um, Joining him is our second panelist, Dr. Sarosh Saleem. Dr. Sarosh is an assistant professor and she heads the bioethics department at Shalimar Medical and Dental College, Lahore. She's also a graduate student of healthcare ethics at St. Louis University, USA. Dr. Sarosh is a physician biocist with trainings in pediatrics and bioethics. She is the co-director of Diploma in Healthcare and Ethics Professionalism at Shalimar Medical and Dental College, Lahore. And she's pursuing her doctorate in healthcare ethics. Thank you so much, all of you, for joining us. Professor John Lantos has also joined us for this panel discussion. With me is Dr. Nuzhat Irfan Malik, who will be leading this panel discussion. And we hope to see questions from our audience as well, so that we can lead this discussion in a very smooth manner. Thank you.
Thank you, Atufa. Assalamu alaikum and good morning to the US and people. Thank you, Dr. John Lantos. It was a wonderful experiences shared by you, and also at the same time heart wrenching. And most of the time, these are the things that we as ethicists face a lot of times. And especially in Jasmine case, I could not relate to it that the parents are not agreeing. So I would request our panelists to share, according to our social, our cultural context, how do you see this scenario in our cultural context?
Thank you, Nuzhat and Atufa. And thank you, Dr. Lantos, for your nice presentation. Um, I wanted to share one case from my own hospital, and but you have asked question, Nuzhat, so I would like to answer that question first. Um, the dilemma that Dr. Lantos has presented, actually, in our own practices, we see that in public sector hospital, there are number of patients are already there, and those who should have been in intensive care or in the incubators, and they are lying on the beds actually, and being referred out from different tertiary care hospitals. Most of them are private hospitals where the patients either cannot afford treatment or they don't find place there. And being a part of a public sector hospital, we cannot refuse any patient. We have to admit them because the government policies here that nobody can leave the public sector hospital. Now, keeping that scenario in mind, and when the parents see so many people, so many children and newborns lying on the bed rather than an incubator, so this dilemma of whether to withhold the support or the nutrition becomes seems to be very, I mean, not quite relevant to our properly probably our setup at this point in time. But yes, over the period of time, we know that when we interact with the parents and the families, we can see their faces, we can communicate even without saying anything through their body language, and through the looking into their eyes, what pain and grief they are actually suffering from. So that is always there. But your specific question whether to go for nutrition or not go for nutrition, probably I don't see this is at this point in time the issue with the public sector hospital, where patients actually need do not even have the basic needs available to us.
Thank you. Thank you, Dr. Jamshed. Um, we have a question from one of the, in fact, it's a question from our side, that decisions between quality of life versus prolonging life is a true dilemma. So, how can we as clinicians put our own beliefs aside and be more mindful?
Uh, Nusrat, if you are asking me, I don't think Sarosh is, she has not unmuted her, so I think probably I'll be answering that as well. Quality of life, the scenario which I have just told you, quality of life then becomes such a redundant word for the people who are not even receiving a primary treatment in our setup. You see, every day, only yesterday, 46 babies, patients were admitted out of emergency in a unit which has only 60 bed capacity. Just think of, I'm not talking of the neonatology and intensive care. These are the separate wards where admissions are also made. So in this context, quality of life becomes such a redundant word for the people. I would say in context of public sector hospital based, yes, that is an important issue. If quality of life, without quality of life, um, uh, prolonging the treatment means that you may be, in a way, if you are very materialistic, that you are wasting your resources on somebody who is not going to have very fruitful person or contribute to the society. Sarosh, if you want to comment on that.
Yes, thank you. Um, Thank you for having me here, and I've been listening to such wonderful opinions and comments. So, yes, answering to that, I think this is true. I mean, we know that all children have fundamental rights, and we all have, as healthcare professionals, as parents, as society, we all have responsibility to protect these rights. But financial issues and economics, it's a very harsh reality in our part of the world. And a lot of decisions, as Dr. Jamshed has also mentioned, they are in our society, in our healthcare system and hospitals, there are most of the times they are based on finances of whoever is supporting for the child's health care, or even wherever the money is coming from. Either it's like set up like in this hospital where obviously there is a pool of money and there is a limited resource available, and as Dr. Jamshed mentioned, in a public sector hospital where you have limited resources and you have to cater each and everybody. So this is a harsh reality. I mean, I think to answer specifically to your question, I think as even Dr. Lantos mentioned earlier, that we can't actually, I mean, we can try to, but we cannot put our emotions or beliefs aside. That's what makes who we are. And when we work together, we bring these things along. However, it is extremely important to put aside our own biases and try to understand, as even both of these speakers said, that try to understand what the patient and the families, where they're coming from and what their issues and what their values and beliefs are. So in Pakistan, what we see mostly is a sort of a unilateral approach towards decision making, and that's mostly based on clinical criteria. And that's why sometimes it's very troubling and difficult for us to understand why a reasonable why some reasonable parents would refuse a treatment that we'd be offering. So it's really important to find out that why would they be doing that, and to reach out to them. So that is an extra responsibility. And probably because in our setup we know that decisions are made like as a community. Individuals don't make decisions, and even for a child, the whole family, even what we call distant relatives, they are often involved. And whoever is financing, who is financially invested, it's emotionally invested in the child's care, they all are a part of decision making. And so it's really important to understand what where their opinions are coming from and why they would refuse and what is happening. And this is the responsibility of healthcare providers, and I think that's what basically is the crux of communication, that we really need to understand. We do have our own beliefs and opinions that they shape our decision making, but we need to also find out. And I don't think we can emotionally separate us. This is again a very this has been a part of our training, and I think in Pakistan we emphasize a lot on this, to compartmentalize everything and not be emotionally invested. But that is not practically possible, and that would not bring out our human aspect of being there for the patients and the families. Any comments from Dr. Lantos or Dr. Shade?
I just would like to add few more things into it. I think in the Dr. Lantos practice, the patients, the families, the doctors, they're all thinking, talking in English probably, and the languages they speak and the values they have may be different in terms of, but because they are advanced nations, they may have been more knowledge. But in Pakistan, we are faced with the dilemma that most of the patients with whom we communicate, we do not know their languages. Many of them are from the cultures that we are not very much used to. Living in Karachi, especially, we find it's very hard to communicate with the different ethnic groups, which actually are actually the number of diseases in those communities is much more, because they are migrants from other part of the country, and they are they basically are here for earning bread for their families. I just would like to share a case where I would like to emphasize is that it's not only the patient and their families that go through dilemmas. Is even the medical communities, the doctors themselves, they are also very much affected when they are dealing with the patients who are terminally ill, because emotions run high, and they are also psychologically depressed. And when they go home, they take burden with them to their families, and they are also affecting their lifestyle as well, and which most of the time we are not actually talking about that. I just would like to share that an 11-year-old, a very healthy child who met with an accident, and underwent a surgery in after resuscitation because he was in a collapsed state, and he was operated, and we found that pancreas, duodenum, biliary apparatus, everything was perforated and ruptured. We tried to do our best to deal with the patient, and the surgery went on to 5 to 6 hours, and then he needed cardiac arrest, went to cardiac arrest, revived during procedure, and then ultimately he went onto the ventilator and with special support. And during the stay, the patient developed 2 or 3 times. He was operated again because of the different complication which he was having during the course of his admission in the hospital. Throughout his stay in the ward, we have been interacting with the parents. And if we go by what is written in the science, that these patients hardly survive, very high mortality in this. So if we go by just the evidence-based data, we could have counseled with the parent that he's not going to survive. But when we looked at the parents and their face and their 11-year-old healthy child, so it was difficult decision. That's very important for the doctors. Just don't go by the evidence there, what is there in the literature, but it's the parents as well. So multiple times when we tried to communicate with the parents, but then we looked at their face and their expressions and their hope. So we actually did not communicate the same findings to them. We were hiding the truth actually from them. But that is, I think, the best decision that we were taking at that point in time. And every time when we go there, they used to ask us. And multiple times during the day in Pakistan, you can approach consultant anytime, anywhere, in the corridors, in their rooms. So it's not like somewhere where you have to take appointment. So every time, the number of family members used to meet the team who was taking care of, and everybody from the team wanted to say something but then when they find the hopes, then they used to actually shut down. But at this ultimately it happens that because they were in the hospital for a long period of time, then they themselves actually started realizing that their child might not survive. I think this is the time when we started telling them, okay, yes, there may be reason for. We were not blunt to begin with. So when we read literature, you should be the truth telling should be there. The parents should be informed, and whatever you want to say that. But that is not practical. Bookish approach is different, but every family and patient has to be individualized. Luckily, this patient, even after going through torment and so many sepsis, septicemic shock, and everything, but finally he actually got better, which was a surprise to whole of us. And that was the time when we were so shocked. And then we said, okay, it's only the God is out there who's actually is going to save us. And I think this was the main belief based upon which both the parents and the families and we ourselves actually were relying heavily upon. So I think religion plays a most important role in that. And over the period of time, because the family was there, they developed, in Pakistan, it's very easy for them to say uncle, auntie, a type of relations which they develop with the doctors actually. So it's not like a very client's type of a relation with them. So they would say, uncle, will our child get better or not? So I mean, these are the type of relationship they have developed. And the surgeon actually primarily who operated upon that patient was also in a type of depression, because the lady was thinking about what I could have done differently, that the child could have survived. And she was also emotionally very much disturbed. But then when she saw that the child is also improving, then we were all very happy. I think the communication that has been done verbally and non-verbally through the expressions and the beliefs that we carried together, and the responses that we see. I mean, these stories actually tell you that every encounter is different. So if you try to make some kind of a policies can be there, black and white, but on in the ground reality would be very different probably. This is what my take on this. Thank you.
Thank you so much, Dr. Jamshed Akhtar, for sharing this case with us. It was very insightful, because a lot of times what we do is we go by the book and we decide that, this person is going to survive or will not survive. And based on that decision, we might take a lot of other decisions that would not have been very helpful. On this same note, you talked about 11-year-old child. Or like, we have a child who's 13, 14 years of age. And my question is more about communication. It's related to would it be okay to communicate with a child who we know is terminally ill about his prognosis, or how can we lead that conversation? Because I think the practical aspects of leading that communication, not just with the adolescent but also with the parents, becomes very difficult. So if Dr. John Lantos or Sarosh, you can share some insights on that, because parental beliefs and parental attitudes related to prognostic communication, related to maybe end of life care decisions, are very firm in our society, or we can say that they lead those discussions rather than the patients leading those discussions. So if you can just shed some light on that, please. Thank you.
Yeah, thanks. Great discussion. Thank you, everybody. A couple of comments to Dr. Akhtar's point about the U.S. being more homogenous, perhaps, and everybody speaking the same language. That's not true. Our hospital has patients who speak 63 different languages last year, and we have translators for all of them. And many of the ethical dilemmas arise because of people coming from different cultures, speaking different languages, and having those different understandings. So I think that's becoming a much more common problem all around the world, just because people travel and move. And in some ways, Pakistan seems more homogenous because almost everybody shares the same religious background. That's not true in the United States as well. And my first case about the withdrawing food and nutrition was in part meant to highlight the role of religion and how different religious beliefs might lead to fundamental disagreements about what ought to be done. To Dr. Saleem's point about the impact on professionals and intraprofessional disagreement, again, the second case was meant to highlight that. And we bring our values. And again, in the US, the health professionals also come from many different backgrounds, many different cultures. Many have different primary first languages and different religious beliefs, so that when we sit down as a professional community and try to have these discussions, we can't draw on a common heritage, a common set of cultural or religious understanding. So that's part of what makes these cases so difficult and contentious. And then the two cases that you brought up, one about communicating a dismal prognosis and the other about whether to discuss a terminal illness with an adolescent, are both examples, I think, of this kind of ethical framework being in transition. 30 years ago, these would not have been dilemmas in most places. Nobody was telling teenagers their prognosis. The parents were seen as people who made decisions, or before that, nobody would have felt a need to include the parents in the decision-making process or let their hope guide treatment. Doctors would have been more autocratic, more paternalistic, and would have made the decision themselves. So this move towards shared decision-making, this move towards including families, is itself a fundamental moral shift in the way we think about who has authority to make these decisions, and it leads to these sorts of disagreements and these sorts of dilemmas. And just a final point on the trauma case that Dr. Akhtar presented, I think it illustrates the need for great humility on our part, particularly around decisions to withdraw life support. We may think there is no hope for recovery. We may think the best thing to do is to redirect towards palliative care rather than continuing aggressive life support. But I think we've all had cases like the one you described where our prognosis is wrong, and that should lead us to some humility when we go and give these prognostic estimates.
Dr. Lantos.
Yeah, Dr. Sarosh, please go on.
Yeah, thank you. So just to kind of add to this and to answer what your question was, I think it's really important, even though it's really important to consider how our culture deals with children, and we have such a paternalistic attitude but it's really important to understand that children have this growing autonomy, and as they're growing, it is really important to make them part of the decision making as well. And for adolescents especially, it's very important, and I personally believe that children who are terminally ill or chronically ill, they have a very different understanding of life because of their experiences, and so their opinions matter a lot. And Atufa, I'm sure you know a lot better than me, dealing with children, oncology patients, that they have a very different kind of perspective and understanding of what life means, and what suffering means, and how they vision life. And so I think it's really important, and not certainly, it is certainly challenging. However, we really need to improve our communication, and deal with children in a way that respect them as persons as well, because most of the time what we see is a very unilateral sort of decision making. Either it's from healthcare providers or from parents, because what we see a lot of times in Pakistan, children don't even know their diagnosis, and don't even know what surgery or treatment they're going through. So for especially for teenagers, growing children, it's really important. And they actually, we don't tell them, but they obviously know what they're going through, because they know the best what they're actually going through and the treatments they're getting and everything. So yes, I think it's we really need to work on that. And I would just like to quickly, the question you've posted about um, supplemental feeding and parental nutrition, etc., at the end of life. I think that's why I shared in this paper. Working in Karachi, and working with some of the biggest tertiary care hospitals in Pakistan who are serving children, I found out that there are no policies. There are no policies, standard procedures that everybody knows of. So decisions are made on a one-on-one basis, for case-to-case basis. It's really important that we make policies and introduce these policies in our hospitals, so that we don't have to make decisions at the bedside. Certainly, the dilemmas won't end, and we will still be making deliberate ethical decisions, but at least it will be helpful. And we really need to do some normative work from what we want to, so because as we talked about religion, it plays such an important part in our part of the world, and especially in Pakistan. Everybody and especially when it comes to healthcare or illness, or talking about death, religion is one of the most important part that we talk about. So but in hospitals at end of life, we really do not explicitly talk about these things. So I think it really needs to come out, and we really need to discuss and deliberate on where our decisions come from, and where should they come from, and how we should be able to make these decisions, because this is such an important part. But all our decisions are made on clinical basis, and we just talked about how evidence-based medicine or prognostication can be so difficult in individual cases. So I think it's really important to do some normative work in our part of the world, and figure out things that on the basis of religion or Islam, that we want to would like to develop, and make policies for hospitals. And we do not have any policies for clinical ethics, and we do not have any systems in the hospitals. So only very few hospitals are doing these things, and very few hospitals have ethics committees. And so I think it's really important that we develop our own literature and do some work.
Thank you so much, everybody, for sharing your opinions. This is such an important topic, and I don't think we have even been able to talk about the tip of this topic. But I think the most important thing is accepting and realizing that there are challenges that we are all facing. May it be financial, may it be related to training, or may it be related to our own beliefs and values. But to just like Dr. John Lantos mentioned in his talk, it is important to have those spaces available where people can come and talk, where people can come and think about what policies should be there, what sort of communication patterns should we be following. As a parting note, one can you all give one suggestion, one practical suggestion or tip on how we can have this culture, this healthcare culture, where religious cultural values, parental beliefs, and the involvement of parents is made possible within our healthcare cultures, and how can it be part of it rather than it being at the very back end? I feel like, it's not like at the front is always making clinical decisions, but considering their values, their beliefs is always comes very secondary, or at times doesn't even come forward. So what can you just share one practical tips on how we can make it possible,
To Dr. Lantos.
to all the panelists, please?
I think the piece of my talk that you picked up on is crucial. Whether it's the role of somebody who's designated as an ethicist, or just a recognition of the complexity of decision making and the need for this, somehow creating a safe moral space where these issues can be discussed so that we can get them out on the table, examine them, and build stronger communities of practice where people understand both the reasons for conflict. Are they religious differences? Are they cultural differences? Are they philosophical differences? Are they differences about our beliefs about the prognosis for a patient, or what's appropriate? Do we have different attitudes about the role of different family members? Is it okay to talk to a teenager about end-of-life decisions? I think people have fundamentally different beliefs, but we need to work together and respect each other. So somehow to create a forum in which, for these tough cases, people can speak freely and be listened to respectfully, and try to hammer out a collective understanding of what we're going to do, not just in an individual case, but for cases like this type of case.
Atufa, I think one of the ways is that we are actually celebrating the World Cancer Day and so many days like this every year. And many of the hospitals do use oncology patient to get more funds from the public. I think that is one forum where, when you are inviting families of the children who actually have survived, but you do not invite those families, the children of whom actually died. So if those can be, you can bring them together and share their experiences, the way they went through, and the decision-making difficulties which they faced, and how they could have been helped more while they were still in the hospital, and with the communities of doctors who have been working with them, and the social, the people in the social setup, working with the people, and also the religious scholars, they can sit together on such occasions and can develop policies for the hospitals.
Yes, I'd say simply first explore more. I think most of the things that we do are based on our assumptions, basically. The study I shared with you, maybe you can share with the audience, whoever is interested. We realize that there's hardly any explicit conversations about religion or culture. It's all about clinical, or sometimes about financial issues. So, we really need to first explore what our problems are, how we can improve our communication with patients and the families. And to be honest, just be more open to a difference of opinion. And just like I said earlier, that when a patient or family or parents are making some decision that might seem unreasonable to us, find and explore what the reasons are. So obviously, certainly finding ways, as Dr. Lantos said, to sit together, explore normatively through cases and stories and everything, and so talk about more, and find better ways of communication, and just as a community. Yeah.
Thank you to Dr. Sarosh, Dr. John Lantos, and Dr. Jamshed Akhtar Definitely, it's a very insightful talk, and the time is definitely limited. And we have to go to the next section. And before that, I would say that just as Sarosh said, that we have to make the things explicit, and communicating these things are not easy, especially when you are and at the situation you're handling these things. So the basic rule that we practice is listen more and talk less, and that usually settles many of the things in most of the dilemmas, because God has given us 2 ears and one mouth, so we should make better use of our ears. And with that, I'll hand over to Atufa for our next session. Thank you very much.
Just one thing, please do fill in the feedback form to get the CME certificate. So moving on, we are in the first section we talked about pediatrics. We were able to discuss about parental beliefs and all of those aspects in terms of prolonging life or prolonging death. Now moving on to the next section, where we'll be talking about adult patients. For our, this section is similarly divided into a talk and then followed by a panel discussion. For a talk, we have invited Dr. Mohammad Atif Waqar, who is assistant professor and founding chief of the section of palliative medicine in the Department of Oncology at Akhtar University. Dr. Atif Waqar is board certified in internal medicine, hospice and palliative medicine, and geriatric medicine with the American Board of International Medicine. He is the program director for the postgraduate palliative medicine fellowship at AKU. Dr. Atif Akar relocated to Pakistan and he began setting up the city's first multidisciplinary palliative care service at Aga Khan University Hospital in Karachi, Pakistan. So, welcome you, and we will move on towards his talk first. Thank you.
My name is Atif Waqar. I'm a palliative care physician and the chief of palliative medicine services at the Aga Khan University in Karachi. And I want to start off by thanking the organizing committee for ICON 2022 for dedicating a session on clinical ethics to this very important yet very neglected topic, which I personally believe is one of the shortcomings of our existing medical curriculum. And by that, what I mean is historically and traditionally, our medical curriculum has focused very heavily on teaching the students and the trainees how to cure diseases. And whenever a point is reached where cure is no longer possible, how to control the disease. We've not been doing a good job at teaching our students and our trainees how to approach the care of a patient who has a condition that is incurable. How do we transition from cure to care for our patients? And hopefully over the course of the next 20 minutes, we'll be able to dive into these very important discussions revolving ethical dilemmas that we encounter in the provision of care for end-of-life patients. Just a slide on my disclosures. I've got no conflicts of interest and I've got no relevant financial relationships to disclose. The learning objectives for my talk today, what I'd like to do is particularly talk about the ethical challenges in terms of decision-making that we encounter on a day-to-day basis in our ICUs, in our wards, and when caring for patients who have terminal illnesses. And hopefully we'll be able to talk about some clinically appropriate ways on how to address such ethical dilemmas when they arise in our clinical practice. So I'd like to start off with this very profound quote by Jalaluddin Muhammad Rumi. And he said, "Every mortal will taste death, but only some will taste life." And I'm truly fascinated by how Rumi, back in the 13th century, was able to very clearly articulate what I do and my colleagues do on a day-to-day basis, which is focus on quality of life rather than quantity of life, trying to empower our patients to have the best possible symptom-free existence with minimal suffering for our patients. And that leads me to something that is very unique to healthcare providers who exclusively deal with end of life patients. Um, the when we're caring for terminally ill patients, it's important to understand that certainty and clarity in the decision making process, that is very challenging. It's very unpredictable. It's very fleeting. What is needed is our ability to accept this uncertainty and this constantly evolving condition of the patient as they're dealing with death physically, emotionally, socially, and spiritually. And given the complexity of these decisions, I wish there was a set of ethical principles or decision-making guidelines that can magically reveal an unambiguous right choice, but unfortunately none exists. It's never black and white for us when we're caring for a patient who's dying. We're constantly dealt with shades of gray, and we're trying to figure out how we can best serve our patients given this rapidly evolving condition, rapidly deteriorating condition, where every hour, every minute, every second, their condition is changing. Our ethical obligation as healthcare providers caring for the dying is to choose the best interventions that meets our patients' requirements in certain situations. The outcome of the decision-making process, it's determined by the patient's unique needs, their values, and the goals of care that we explore with them. There is no formula that can guarantee an ethically correct decision in all situations. The decision-making guidelines that we do have, they can help to clarify the rights and the responsibilities of the patients, their family members, of the healthcare providers who are providing care. And it can also help to reassure society as a whole that deliberate decisions are being made in accordance to the relevant medical facts and the accepted ethical values. So with that, I'd like to list the various ethical challenges and the ethical dilemmas that we encounter on a day-to-day basis in providing end-of-life care. This list by no means is an exhaustive list, but at least it highlights the very important and very common ethical dilemmas that we face. And the first ethical dilemma is pertaining to autonomy, specifically talking about how autonomy is honored and respected in our society in Pakistan. Often we see this on a day-to-day basis where patients are often kept in the dark, where diagnoses, specifically terminal diagnoses, are not communicated or shared with the patient. And we have family members who are acting on behalf of the patient, patients who still do have the capacity to make decisions for themselves. But before I dive into that, I think I'd like to share some very profound insight from my esteemed colleagues, Dr. Farhat Moazam and Dr. Rubina Irshad Khan, and I'll be reading verbatim what they shared. Being a patriarchal society for centuries, adult male members are considered the head of the family. Diagnosis and prognosis of terminal diseases are shared with them rather than the patient. These facts are usually hidden from the patient to have a positive outlook. Lives of extended family members are entwined in a way that nothing is considered confidential. The concept of individual autonomy is overridden by familial or collective autonomy. Um, This is something that we struggle with on a day-to-day basis. I've had many of my colleagues come to me in moral distress because they feel they owe it to their patients to share the diagnosis, particularly terminal diagnoses, with the patient themselves. And whenever their family members tell them not to disclose that diagnosis, I think we need to understand that individual autonomy in the true sense is a Western concept. And for us to try to transplant that Western concept of individual autonomy in our culture, in our society, with our values, with our beliefs, is a disservice. We need to understand that we need to adapt that concept according to our values here in Pakistan. And it's not just medical decision making. It's pretty much all major decisions, whether it's relating to finances, uh, uh, purchasing of assets or land, or um, deciding marital affairs. Um, uh, we've always done these decisions collectively as a family, and we've always turned to the older adults in our families who kind of um, dictate how decision making happens in the family. Um, so just keeping that in mind, of course, we don't want to blindside patients, and the truth telling is equally important. I think the best approach in such circumstances is to approach the patient and ask them, are you the kind of person who would like to know the big picture, or are you the kind of person who wants to be bothered with the minute details in regards to your treatment and the decisions regarding your treatment? And and you'll get a good sense of where the patient actually wants. Sometimes the patient may say that they do want all of the details, and they do not want to be kept in the dark. And in those circumstances, we owe it to our patients, it's our ethical obligation to share the diagnosis and the information in terms of the treatment and the management plan with the patient. Of course, having family members over there is always very reasonable because they can help to guide the conversation. But very often, what I've encountered, especially with the elderly population, the geriatric population in our society, is they will delegate decision making. They will tell us to talk to their son, to their daughter, to their husband, to their wife. And the reason they do that is because they know that their loved one has the best of intentions at heart, and whatever decision that they're going to make is the decision that the patient will take solace into. So with that understanding, if the patient does delegate the decision making to their loved ones, I think we can be reassured that that delegation is itself an autonomous act, and we are honoring and respecting autonomy if the patient has delegated autonomy to their loved ones. The next and very important thing that I would like to discuss is medical futility. Often this medical futility is this term is thrown around left and right without truly understanding what medical futility entails. Um, Even in the medical community and the medical fraternity, we struggle to define medical futility. We don't have a clear-cut definition. But what I can share with you is, for all intensive purposes, whenever we refer to medical futility, basically we're talking about a condition, a situation where the patient is irreversibly dying, and the patient has reached a stage where continued disease-directed treatments are likely not going to produce any kind of physiological benefit. And at that point, um, whether we decide to continue the treatment or forego the treatment or terminate the treatment, it truly becomes optional. So that would be the medically correct definition for medical futility. What we need to understand is appropriate medical treatments do not necessarily have to include every effort to prolong life, regardless of the quality of life. In fact, we need to recognize and we need to understand as healthcare providers that what should be done for a patient who has an acute reversible medical condition might actually be burdensome and unnecessary for a patient who's got a terminal illness. And to make that a differentiation is very important for us so that we don't end up prolonging the suffering of our patients. Rather, we focus on what's important, which is keeping them comfortable and providing good end of life care. And this goes back to what I shared with you at the beginning of my talk, which is the way that physicians equate cure of diseases with success. And if their patients cannot be cured of their ailments, they internalize these feelings because for them that is accepting defeat. And we, as clinicians, we're a very stubborn bunch. We don't want to accept defeat, which is why we continue down this road of providing very aggressive and very invasive treatments one after the other. In the oncological realm, we continue to provide first line chemotherapy, second line, third line, fourth line. We just never know when to quit. And what that does is that provides unnecessary toxicity to our patients. And rather than improving their quality of life, it just causes more unnecessary suffering. So we need to focus on what we call a good death. And the best way to define a good death would be an unprotracted, painless death without any kind of suffering, both to the patient and the family members. The next very important concept and ethical dilemma that we share in the provision of end-of-life care is withholding and withdrawing life-sustaining treatments. So life-sustaining treatments in traditionally, the way that it's been defined is a CPR, elective intubation, mechanical ventilation, and then the utilization of artificial nutrition and hydration, whether it be parenterally or enterally. But we need to understand that life-sustaining treatments can actually include a lot of other interventions, for example, surgery, dialysis, antibiotics, medications, hospitalizations. All of these could be argued to be life-sustaining treatments. From an ethical standpoint, we need to understand that there is absolutely no difference between withholding a life-sustaining treatment versus withdrawing a life-sustaining treatment. And to give you an example, if a patient comes to your emergency department in extremis, in respiratory distress, and you identify that the patient is in need of mechanical ventilation, and you have a conversation with the patient and their family members, and they elect not to be intubated, and they elect to allow the disease to take its natural course, that is what we would consider withholding intubation or withholding life-sustaining treatments versus the same patient presents to your emergency department, you intubate the patient, you give the patient a time-limited trial of aggressive treatment in the ICU, at the conclusion of which the patient continues to deteriorate. And then finally, you, based on the poor prognosis and consulting with the family members, decide to withdraw the life-sustaining treatment. From a medical standpoint, of course, there's a huge burden, emotional burden, psychological burden that we as healthcare providers, the next of kin, have to shoulder, because it becomes very, very difficult for us to withdraw interventions once they have already been initiated, versus it's easier for us to accept if a life-sustaining treatment is not initiated to begin with. So withholding, we can make our peace with it. With the withdrawing becomes very challenging for us. And that leads me to advanced care planning, which is a very important tool in providing good end of life care for our patients. By advanced care planning, what I'm trying to talk about is understanding and exploring the goals of care for our patients. What is important to them? What is the kind of treatments that they would want and the kind of treatments that they would never want for themselves should they develop a terminal or life-limiting condition, and they should lose the capacity to make their own decisions. So one of the advanced care planning tools that we use very commonly is called advanced directives, which is a legal document where a patient who still has decision-making capacity can actually complete two components: a living will to identify the kind of treatments in terms of life-sustaining support that they would want and the treatments that they would never want for themselves. And number two, completing a surrogate decision maker, a healthcare proxy, to identify who would make decisions on behalf of the patient when the patient can no longer make decisions for themselves. Other advanced care planning tools includes out of hospital do not resuscitate orders and the POST, the physician orders for life-sustaining treatments. All of these are very valuable and very important tools that we can utilize in order to empower our patients so that they can decide in advance the kind of treatments that they would want for themselves and forego life-sustaining treatments, especially in light of a terminal or life-limiting condition. And the last important concept that I would like to touch on is the doctrine of double effect. And by that, what I'm referring to is a single act which may have two foreseen effects, one good and one harmful. That is not always morally prohibited, provided the intention is to benefit the patient and harm is not intended. Usually, a very common example is the use of opioids and controlled substances at the end of life. And often there's a hesitancy to prescribe these medications because they may potentially shorten the lifespan by producing a respiratory depression. What I wanted to share with you that the doctrine of double effect actually protects the healthcare provider because it's the intention with which the medication, the opioid, is being prescribed, and the intention is to relieve suffering and air hunger or pain in patients. The intention is not to cause death. And by virtue of that, it allows us to ethically and morally prescribe such medications. So with that, I come to the conclusion of my talk, and I would be glad to engage with the participants in our question and answer session at the end. Thank you very much.
Okay. I would like to thank Dr. Atif Waqar for such an interesting and insightful presentation. What I took from his presentation is that culture factors and all of the things that are Western cannot be directly put forward in our culture, in our settings. So, with this, we'll move on to our discussion. For the panel discussion, we have been joined by Dr. Farhat Moazam and Dr. Aisha Malik. Dr. Farhat Moazam is the professor and founding chairperson of CBEC at SIUT Karachi, Pakistan. She has also previously served as the founding chairperson of the Department of Surgery and the first associate dean of postgraduate medical education in AKUH. Joining her is Dr. Aisha Malik. Dr. Aisha Malik is associate tutor at University of Warwick. She also teaches as bioethics at University of Oxford. She's expert member of the Research Ethics Committee, Health Research Authority. She is a hematologist by profession, and her teaching commitments include medical ethics, both clinical and research, and Islamic medical ethics applied, and bioethics. I would give the lead to Dr. Nuzhat to conduct the panel discussion.
Assalamu alaikum. Thank you very much, Dr. Atif Waqar. We could really relate to the points that were raised in your talk. and welcome Dr. Aisha and Dr. Farhat Moazam as a panelist of this session. And I would like Dr. Aisha Malik to throw light on the religio-cultural aspect of communications in these difficult times, and how we can bring the religion and the cultural context in these scenarios.
Can you hear me? Assalamu alaikum.
Yes, we can hear you, Dr. Aisha.
This was a very, very insightful talk by Dr. Waqar, and there are so many points that he made. If I could just make a couple of comments on what Dr. Waqar said, that certainty is indeed an elusive concept and in medical decision making, and particularly when patients' conditions are ever evolving and prescriptive guidelines in many instances do not work. Of course, everybody wants to work in the best interest of the patient, though they may have different views about that best interest. Here, I would like to add that, keeping in mind the goals of care, we could use what I have been working on is a phronetic framework, a practical wisdom framework, which I think Dr. Waqar also alluded to. And keeping in view that familial autonomy versus individual autonomy or relational autonomy is important. And from our cultural point of view, yes, relational autonomy is important. And as Dr. Waqar said, that it is not necessarily heteronymous, but autonomous if the patient wants somebody from the family to decide in there. And I think that goes in relation to the proxy decision making also, because if there is somebody I rely upon, I will ask that person to make decisions on my behalf without feeling that I'm being pushed into asking somebody. Although, of course, there are instances where one can be pushed, and we have to be aware of that. Then keeping in view the fact that open communication is a very important aspect of a doctor-patient relationship. And the art of dying, that I think, the good death Dr. Waqar mentioned, that relates to the Islamic point of the art of dying, or which was termed as the ars moriendi, a good death, the art of dying. And what does that entail? That entails the acknowledgement of a dying state. Then one can decide their preferred place of death. What is it that they would like to leave as a legacy and charity behind? Then being able to communicate with your loved ones. And what are the the rituals at the end of life, like especially for Muslims, to be able to recite the Shahada, to be able to recite verses from the Quran and things to that effect, being turned towards the especially the Qibla. Then these decisions should be preferably autonomous, even towards, especially towards the end of life, and that is the Sunnah. Now, when it comes to death and how we perceive death, the important thing to remember is that in Islam, death is not the end. The life here transfers to the afterlife. And for a Muslim, that is the basic concept that makes them go through. So that this life is temporary, and we are going to transfer to the afterlife, which is permanent. And our trials and tribulations in the form of, relationships or health are just that. They're trials and tribulations, and if we go through them, then we will either receive, the good life or the bad life. The important thing here is that all Muslims who are practicing Muslims and who have a belief in Islam, or who are Mu'min and who are Mohsin, is that tawakkul, that our illness as well as getting better are dependent upon the will of Allah. So we will seek treatment with this thing in the background that if we get well, it is due to the will of Allah. So this tawakkul, and related to it or attached to it is tawbah. So they are both related to each other when it comes to a Muslim's faith in getting cured, being cured or not being cured, and then going towards the end of life treatment. The important thing that Dr. Waqar mentioned, and which I think is very, very useful, is this advanced directives. This, I think it probably is new, but it is something which should be brought out and discussed with the patients. Yes, we must be careful. We must be careful as to each particular case there's no one size fitting everything. Each case has to be on its own merits, and each case has to be discussed with the patient and their family if they want to. But it is important that each, like I said, with this ars moriendi, or the art of dying, to be able to plan ahead what is it that they would like to have done, in case of emergency treatment or in case things deteriorate. So from that point of view, I think the idea of introducing advanced care plannings, or what we have in the UK as the RESPECT, the recommended summary plan for emergency care and treatment for, either end of life or patients who are going on for palliation.
Thank you, Dr. Aisha. You're very right in saying that the religious plays a really strong role in these end-of-life decisions, and especially in our part of the world. We've seen multiple cases that I can recall one case where a child was on the ventilator, and the father just wanted to continue the ventilator for 48 hours because he was going to a healer, and he believed that a miracle would happen. So we believe that each case is different, and you just cannot see all the cases. You cannot put them under one umbrella. So what I have been thinking while dealing with such cases, and I believe that most of our colleagues must have been through this. So we should have, Dr. Farhat, I would address to you that do you think that we should have some sort of hospital guidelines, especially when there are multidisciplinary teams are included, and they all have their own opinions, and sometimes it's really difficult to bring them to a congruent point. So, Dr. Farhat, would you please add on to this?
Dr. Farhat, we are unable to hear you.
No video.
Dr. Farhat, we still can't hear you at this moment. Just a second. Let us just check it out with our technical team. Dr. Farhat, can you try again without the video, maybe? Actually, I think we'll move to a question for Dr. Atif Waqar at this moment, and then we can sort out how we can take Dr. Moazam on call or some way. एक मिनट, sorry, मैं question कर लूँ डॉक्टर आतिफ से एडवांस केयर प्लानिंग पे.
हाँ.
Okay. Dr. Atif Waqar, I have a question for you. Going forward from the discussion that Dr. Aisha did right now, advanced care planning is something that seems very promising, especially in terms, just like you spoke about, that a patient is intubated in the ER, and then we see how futile that is and how difficult it is for the families to then accept the fact that we are withdrawing that sort of a treatment. So in a resource limited country like we have been talking about since the initial part of the session, how can we make sure that in our OPDs we are able to see what sort of wishes does the family have? Sorry, what sort of wishes does the patient have, and are they in congruence with the family? Because a lot of times when the patient is not in a position to make a decision, then the families come forward, which is our culture, the interconnectedness, the collectivistic culture that we are part of. So how do you think we can make it part of our everyday conversations with our patients? Dr. Atif, we are unable to hear you as well. If it would be possible for you to maybe switch off the camera so that we can hear you properly. Dr. Atif, can
Yes,
you, from a
yes,
technical
Dr.
team,
Farhat,
they're
I
saying,
can
can you
hear
move to a
you.
place where maybe the internet is a bit better because we can't hear you even without the
Dr.
video.
Farhat, just a minute.
Okay, so Dr. Atif is going to reconnect with us.
So Dr.
Dr. Farhat Moazam is on
with
call
us
with us.
for
So we'll ask her to share her views regarding the question that Dr. Nusrat had posed towards her.
Dr.
first.
Farhat, you can
Thank you.
please proceed.
Okay, can you hear me?
Yes.
Okay, so the question that was asked was essentially about the issue of religion.
No.
And I would like to answer that because the issue is when you talk of religion, there is, and can out of that, can there be some guidelines or other things that are available that can be helpful to physicians? The issue with Islam is that there is no one particular madhab. There are several madhabs and there are differences of opinion that occur even amongst the fuqaha. So the issue therefore is that, as I had said on the chat, you cannot, in clinical medicine, it is almost impossible to come up with any specific policies, etc. So the issue is every patient is an individual patient, every case is different. So I think you have to understand what a particular, two Muslims will have different values. You can have fuqaha who can give you guidelines, etc. But in the arena of the clinics, each patient has to be dealt with, and as we have said, you need to talk to the patient, find out what their values are. Their values may be different from your values. You and the patient can be a Muslim, but the values are different. I would like to take up another point, which was, number one, I would like to thank Dr. Waqar, as usual. He gave a very, very lucid presentation. The point I would like to talk about is on advanced directives. Now, advanced directives is something that came into the United States back in the 1980s. But advanced directive has not worked very well, and let me explain to you why. The problem is, if I, at the age of 40 years, make an advanced directive, by the time I'm 65, I may have changed, essentially, the way I look at life. In the United States recently, an intensivist has written about it, that a patient with an advanced directive came in 10 years later and wanted everything done. So the point I'm making is, and I think Dr. Waqar alluded to it, the issue is to proxy decision making. And in Pakistan, one of the things is that all of us, we don't like to talk about death. Culturally, in Pakistan, nobody talks about death. You cannot go to your father and say, can you please tell me what you want me to do when you're dying? It's not done. So the cultural context is the education, maybe not our grandparents, but us, people at our age and younger, that we begin to make our wishes known to somebody who knows my values. So that when I am not able to say what I want done, the physicians have the proxy with who to work out the end of life care. And perhaps Dr. Waqar can say something about this, because this is important. So what has come up is when we take bioethics from the West, and this came up also in the first half of the sessions, we tend to pick up things like autonomy. Now, as Dr. Waqar says, in the United States, people are beginning to understand that this is a very difficult concept. But we in this part of the world pick up these terms, and then we face problems with application. So the issue of it, I don't think it's family autonomy. I don't like the word autonomy. We live together. We rely on each other. We are very, very interdependent, which includes the economical issues. And therefore, the decision making has to bring in, whether we like it or not, the patient, but also the family. And each family is different. Working in Indus, for example, is different from working at the Aga Khan University. And it's different from SIUT, where our center is there, because the situations are very different. So I would like Dr. Waqar, if he can join us, to tell us a little bit in his experience, this issue of advanced directives versus the suitability in Pakistan because of the culture we have, going and pushing and understanding proxy decision making. So I don't know if Dr. Waqar can join us. We are having some problems with it, but I'll stop there. So when we talk about Islam, we have to be very careful what we are talking about. All of us sitting around here know that we are Muslims and we have very different values. So I'll stop there. Thank you.
Thank you, Dr. Farhat.
Okay,
Can I,
we'd like to see if Dr. Atif Waqar is able to join us and we're able to hear him, or else we can take him on call as well, if that's possible.
can I just make one comment here, Atufa?
Ji, Dr. Aisha,
The thing is that advanced care plans or directives and proxy decision making are not mutually exclusive. You see, even with the advanced care plans, families or the person you are related to do sit around and make those plans. And at least the person who's at the center of the whole situation is able to give some voice to what ought or ought not to be done. And I think they are quite related in that sense. So Dr. Moazam also talked about values, and so where evidence-based medicine and value-based medicine, that is also coming up as a form of practice, isn't it? That you give this, look, the evidence-based medicine says, okay, 1, 2, 3, these are the treatment options. And the values of that patient come into play, and you say, well, treatment 1 may be the best treatment from the clinical point of view. It is not coherent with the values of patient A or patient B. So all this All this needs to be juggled around and then a decision made which is in the best interest of that patient's values, that coheres with that patient's values, as well as medicine. So the two may not be, so when it comes to decision making, yes, it is important to have a shared decision making model. And in our culture, yes, relationships are important, but we must be aware also. We must be aware of like we said earlier and Dr. Waqar mentioned, each case has to be decided and discussed as an individual, as an individual case in itself, and not given a prescription that
Okay,
this is
you
a
can
prescription
stay
you
on the.
should follow.
Thank you so
Right.
much, Dr. Aisha, for sharing your thoughts. And this is true that advanced directives focus on who the person is and then bring in the family to a discussion about what is important. I would just like to share a little bit about what we practice in our department as a whole. What we started to do was we started to talk about death, about our own deaths. We started to have conversations around the fact that if I die, would I want, if I am towards that end of life, would I want to opt for a ventilator? Have I, decided, have I prepared for my own coffin and all of those sort of things, which made us more comfortable discussing death with our pediatric patients as well. So we'll try and see if Dr. Atif Waqar is available, and we can hear him, or else I'll just take him on call, like we did with Dr. Farhat Moazam. Sorry, we are still unable to hear Dr. Atif. If it's okay, can I call you on your phone so that we can hear your thoughts?
Can you hear me now?
I'll just ask my participant.
Yes, can everyone hear me now?
Yes, we're able to hear you now.
Okay, thank you, Atif. I apologize for the issues with the microphone. I'm so done with all of these online and Zoom conferences. I'm just waiting for the fifth wave to go away, and we can go back to the glory days where ICON was done physically and all of us could meet in person. Once again, my esteemed colleagues, Dr. Farhat Moazam and Dr. Aisha Malik, they articulated it so well, and I couldn't have said it better. But in full disclosure, unlike my colleagues, I don't have a background in ethics. And by virtue of my specialty, I deal with such situations where experientially I've taught and trained myself, and what I'm sharing with you is my own personal experiences. Unfortunately, we don't have advanced directives in Pakistan, and as Dr. Moazam has shared, the expected outcomes that we wanted with advanced directives, unfortunately, the evidence didn't support it. And it's embarrassing for me as a palliative care physician to admit this, because I'm a huge proponent of advanced directives. This is what I do for a living. What we do know is that having an informed discussion, an inclusive discussion, members present for that discussion, it makes a huge difference. And the reason being is
often when the burden does fall on the family members, it's hard for them to make any kind of decision. But when they actually hear their loved ones say this, articulate this, verbalize this, it takes a huge burden off of their shoulders. And it makes it easier for them to understand where their loved one, their father, their mother is coming from, and then for them to honor and respect those wishes, irregardless of whether or not they agree with that wish. Because, let's face it, when it's our loved one, we don't want to see them go. And often we, in the moment, become very selfish, and we try to hold on to them for as long as possible without any regard to the quality of life or the pain or suffering that they're going through. But this discussion, and we need to understand it's not just a singular discussion, it is a discussion in flux that continues to happen on repeated visits, because as the patient and their medical condition changes, their goals and their values change as well. And we try to understand what is important to them. And we try to engender hope, which is really important. Often the patients, they do become hopeless, and we don't want them to lose hope. Even in the face of a terminal illness, we want to engender hope, but we've got to be careful. What kind of hope are we talking about? And we're not talking about hope, false hope for a cure. We're talking about hope in terms of finding new meaning in life. And now that you've been dealt with this serious and life-limiting condition, what are the things that are important to you? What are the milestones that you want to achieve? And once myself and my team are able to hear that from the patient, our obligation and our responsibility is, how do we make that happen? And then we try to follow through on that, and we honor and respect their wishes and their choices. So I hope that answers the question. Thank you.
Thank you, Dr. Waqar. Dr. Waqar, there has been a few questions posed, and there are like two questions that, what do you mean by a good death?
So Dr. Nusrat, again, Dr. Aisha Malik answered that question so beautifully that I honestly don't have anything else to add to that. But she very, very appropriately was able to delineate and identify and outline what entails when we talk about a good death.
Right, thank you.
This is something. Sorry, can I come in here?
Yes.
Yeah.
Yes,
This is
Aisha, please.
the art of dying, or the ars moriendi that I was talking about. If you look at Prophet Sallallahu Alaihi Wasallam's death, you would be able to differentiate all these various points that I made from that. And that is that the acknowledgement of the dying state and your preferred place of dying, where he wanted to, go to the afterlife or transfer to the afterlife, communicated with his loved ones, and then what was the legacy that he left behind, and the charity, whatever charity he left behind. So all these things are part of our religious, the broad religious framework that Prophet Muhammad Sallallahu Alaihi Wasallam left. So this art of dying, or the good death that Dr. Waqar alluded to, is indeed. I think when Dr. Waqar was mentioning that they have these discussions, and I think that is a good starting point for the ethics of end-of-life discussions. And I don't know, what do you think, Dr. Waqar? Is that not to have these discussions, like Dr. Lantos was saying earlier, to have these public spaces or spaces where you can talk about these things? It's important to make people talk about these things, so that fear, that there's always this fear of the unknown, and death is an unknown. To get to overcome this fear, we all have this fear. We have many fears, so it's always best to be able to overcome this by talking. And I think Dr. Lantos's talk earlier, and then Dr. Waqar's, that to have this discussion or this conversation, not only with the patient, but amongst ourselves as clinicians and healthcare workers, nurses, clinicians, everyone, this would be a good beginning.
You want to go?
Okay. Thank you so much, everybody, for sharing your views on this very important topic. I think what we all take from this discussion is that these decisions can be very difficult. These conversations can be very difficult, but they are possible. It's not like that this is a box that needs to be covered all the time. This is a box that needs to be uncovered, that we need to keep on going back and forward, not just with the patients, whether they are pediatric patients, whether they are adult patients, whether they are parents, but these conversations need to happen within the clinical teams as well, so that we all are, at least if not completely aware, but a little bit more mindful, and we are able to see where ethics comes in, and where ethics plays its role, which is very, very, very important with the population that we are dealing with. We are really sorry for the technical errors that we had in between, in times of virtual conferences. This is something that we all struggle with, but thank you so much, everybody, for staying with us. I would now like to hand it over to Dr. Nuzhat to conclude the session, and we just thank all of you attendees as well as participants for being part of this.
Thank you, Atufa. Yeah.
Just one point, the plurality of opinions in fatwas, and plurality of opinions anywhere is a good thing, especially when it is said in fatwas, because then that gives you a broader leeway, rather than being, what you get in the blinkers on the side and just follow one, which is going to cause problems for everybody. So there, I'm sorry, I got,
Yes.
okay.
Thank you, Dr. Aisha. Before I conclude, there's a comment from Dr. Farhat Moazam. I would just like to read that advanced directives are legal documents, pragmatically not feasible for general population, but having a proxy who can communicate with the doctor is doable if we can educate our public to begin to speak of what they want with their close family members. We have all the speakers. Okay, with that, I conclude the session, and the take home is that creating awareness in healthcare workers is the key aspect. And without creating this awareness, we cannot expect, especially the young doctors, to jump to conclusions and to decide on their own. And learning the art of communication is part of it, very important part of it, I would say. And one thing that I learned from today's whole of this, especially from Dr. Waqar's, was that going forward has no limit. We as doctors, we are obliged to save lives, and we really want to progress to every limit, to cross every limit, to prolong not only just to cure the patient, but prolonging life. And I have witnessed a patient who lived for 8 years in a vegetative state because the family and the doctors, it was the family's wish that the patient should just be living with us, whatever is the condition. And I don't know what was the feeling of the patient in those 8 years. He was just alive with rolling eye movements. So it's also the art of learning where to stop. We do not know where to stop, and making this awareness that there is a limit and we have to stop at some point. And especially like the financial burdens are also along with these things. And in the end, I would say that it's the quality of life which is more important than quantity of life. And this is what the take-home message would be. Atufa, you can add your views as well.
I'll just add my views in terms of my experience working with pediatric patients and a lot of oncology patients, is that these conversations are for a choice of better word, I would say magical. Because to see a child dying with dignity, that Dr. Aisha Malik has mentioned in her chat, dying with dignity and living with dignity, and quality of life is something that we all want. But what we want for us, we need to give that to our patients. I'm not very well aware of clinical terms, clinical outcomes, but because I'm a psychologist by profession, but working with clinicians, working with healthcare teams, I've come to realize everybody wants the best for patient. um, it's just that having these conversations again and again and again would help us all perfect our art, or maybe not perfect our art, but maybe better our art of providing such amazing treatments. And thank you so much again, everybody. And we would really love to welcome you all in person to our hospital and to our CECs as well, so that you can enlighten us more with your experiences and with your opinions and feedback. Thank you so much. And just last thing that I would like to add, please do fill in the form for the e-certificate, to get the CME certificate.